I don't know if I'll see it, so let me know, Mark, if you are recording.
Recording now.
All right. Good morning. Thank you guys for being willing to adjust your schedule to allow for a change in the time for presentations for case reviews in August. I hope that that you guys find these next 4 cases pretty interesting. I thought that they were pretty interesting and hopefully sparks conversation amongst us, if not in your own departments. As always, we talk about that this information is private and confidential and that it's protected, so do not distribute it, copy it, or discuss it amongst people outside of our system.
Hey, Jackie, we can't see your screen.
Oh, you know why? Because I'm not sharing. Can you see it now?
Yep, perfect.
Right.
Thank you.
Yeah, thanks. So moving on to case 1, which was a 58-year-old patient who EMS was called for shortness of breath. When they got there, the patient was not obviously short of breath. It looks like they ascertained that he complained of a abscess to his left hip and that he was having a lot of pain. I don't recall there being respiratory physical exam, but I think that it was just based off of the fact that he looked to have other reasons that he wasn't overtly short of breath. PPE usage was maximum, and the vital signs that were obtained were by the first on-scene agency, which was the fire department. They documented that the heart rate was 120. He was hypertensive at 176 over 121. No respiratory rate was recorded. GCS of 15, and his room air sat was 100%, and he was a 68-kilo gentleman. Primary survey is that this patient was awake. His area was open. He was protecting it, and they documented that his skin was pink, warm, and dry, but they also documented that, which I thought was kind of interesting in the narrative, is that he was not in any distress, which it's in case reviews, so you can imagine that that probably would been something that maybe have changed. Anyways, past medical history was that he had a history of substance abuse and hepatitis. And his substance abuse of choice, at least in this documentation and in this encounter, was IV drug use with use of heroin. He was known to be a skin popper. He popped mostly to his buttocks, and he tried to pop what he thought was an abscess the night before, and he had presented to an outside hospital, not within our system in the Portland area, but had reported not this didn't come from our EMS documentation, but it came from the emergency room documentation, was that he was told that it would take him 2 hours to be seen, so he decided he didn't want to wait. So I don't think it would have changed his outcome, but unfortunate. So prior to arrival, we were just reported, and this contact occurred at 9:20 in the morning at 10 minutes. So the physical exam is that they did look at his buttocks, and they said that there was edema, swelling, erythema, and flushing. At 10 minutes, the patient transport was initiated, and at 20 minutes, the transporting agency records their set of vital signs: heart rate of 96, blood pressure of 172 over 130, respiratory rate of 20, and GCS of 15, now SATs of 98% on room air. They also had spent the time to document that the patient asked for pain meds multiple times and that his pain was a 10 out of 10, but as you can see, there was no interventions performed on this patient. They did also document that the patient would go in and out of sleeping, which I thought was a little bit interesting. And then at 25 minutes, the patient arrived to the hospital. So after reviewing the pre-hospital side of things, I thought that, of course, this was a case that the hospital brought to me. And I thought that I was really happy to see that we evaluated the area with our own eyes, which oftentimes, if it's any kind of private area or a genital area, that it can be omitted or passed on to be done by the hospital. So excellent that they assessed the area. They documented the history of the present illness. There was 2 set of vital signs, although I would love to have seen, especially with the first abnormal vital sign, an earlier set of second vital sign, and potentially 2 with the transporting agency. And that they didn't spend a bunch of time on scene, kind of slowly moving towards the hospital. So areas for improvement, at least attempting to get IV access. I understand this patient was an IV drug user and it may have been difficult. I think that their index of suspicion for what was going on with this patient was not where it could have or should have been. And then I don't understand if we're not going to treat somebody's pain, I don't think that it's necessary to put it in the narrative that they asked multiple times and by our actions, we did not do anything about it. It's something I think I would just recommend omitting, unless you think that there's something that you're trying to prove, which I think there's probably better ways to prove that than just saying that they requested pain meds multiple times. And then consideration for a temperature and an end tidal CO2, specifically because you've got a patient who initially the call was for shortness of breath, but also you've got a patient that you have an infection and trying to suss out, does this look like it might be sepsis? So in the emergency room, the patient had reported to the team that he had an abscess to this area for many months, but over the last couple of days, it got profoundly worse. He had told them that he's been having subjective fevers and chills, and yes, he's an IV drug user, last using yesterday. An IV drug user, as just like a knowledge point for those that are not aware, is not just injecting into the vein, it's also skin popping or injecting subcutaneously is considered IV drug use. His temp upon arrival to the hospital was 36.9. His heart rate was 117. His blood pressure was 112/72. His respiratory rate of 13 and his SATs of 94%. And just as a reminder, he was initially tachycardic with pre-hospital. The vital signs, the subsequent second vital sign showed resolution of his tachycardia, but he was pretty hypertensive both times with our vital signs in the pre-hospital setting, now has had a substantial drop. They called him a sepsis alert because he looked very toxic, and when they looked at his area of involvement, they were concerned for a pretty bad infection. So they upgraded him. They treated him empirically with antibiotics, and they received cultures and labs. His initial labs were pretty concerning. So we got this call. Let me double check what time that was. 9:20. His initial vital signs at 10, or his initial labs at 10 o'clock in the morning were a pH of 7.1. His bicarb was 11. His lactate was 14. His sodium was pretty low at 127, and his white blood cell count was 81,000. By 12:30, his blood cultures came back positive for MSSA, and they had already had sent him to the CAT scan to image his abdomen and pelvis prior to the results of the blood cultures, which was at noon. So 2 hours later, he had air tracking into his soft tissues and then all the way down to his bone and into his left hip prosthesis that he hadn't recently been done, but had a history of a hip replacement. They noted that when he got back from CT, he started to become altered. They were concerned about his ability to protect his airway. They decided to, because of how sick this patient was, they decided to intubate him using ketamine and rocuronium. He developed hypotension, followed by a PEA code, lasting for about 7 minutes before they were able to get Rosk back. And he immediately went to the operating room, which that was reported to be just shy of 2 p.m. His repeat vital sign or repeat labs at that point showed a pH of 6.6, a PCO2 of 68, a bicarb of 8, and a lactate of 19 at that point. So profoundly sick, and subsequently had a worse progression through the emergency room before going to the operating room. In the operating room, they debrided what they could, but basically they they had documented that there was necrotic tissue all over, not just his buttocks, but extending up into his upper back and his low legs. They decided that any further debridement would be futile and that ultimately there was nothing to be done, that his infection was too severe. So they discontinued further debridement and brought him to the ICU. In the ICU, he was in shock. He was maximally treated with 3 pressors and stress dose steroids without improvement in his hypotension. They couldn't get a hold of any next of kin, family members, decision makers. So ultimately, nobody was contacted, and he passed away shortly after shortly after getting to the ICU. Anybody have any thoughts or questions before moving into what was going on?
Just out of curiosity, Jay, was there any, is there any documentation in there as to why they didn't give pain medications?
No, that's what would bug me, was that they didn't. The only thing that I can think of is that they wrote the patient requested multiple times for pain meds, and then in the vital signs they documented his pain as 10 out of 10. Both times that vital signs were, both times that it was in the transporting agency's pain scale. But then the next line after that says that the patient falls asleep. So I don't know if they're trying to impress that they thought that the patient was drug seeking or that he wasn't really in that much pain.
But they had examined his buttocks and genitals, and he had a problem.
That's what that's what they document, and that's what the hospital brought up to me, was that, gosh, like, we get a lot of alerts. Well, how come, like, this guy looked really bad, even though he only had tachycardia, when, that would meet our sepsis criteria for the hospital.
Mhm.
So, I mean, if we're looking at vital signs, the only abnormal vital sign, yes, is tachycardia, but they were surprised that this patient seemed to be dropped off as more of like a run-of-the-mill kind of patient.
Well, his hypertension along with tachycardia is a little concerning too.
Mhm.
Okay.
Yeah.
No, I think these cases are really hard, and it's frankly, it's one of the things that I find most challenging about emergency medicine, is that you're meeting someone for the first time, and they say they have terrible pain, and you're trying to figure out, well, how do I assess this? And but I think you have to assume that if someone's saying that they have severe pain, that they're trying to tell you something. I think it's
Right.
great that they examined the area in question. And I think the other thing that I take away from this is just that IV drug abuse is probably the most hazardous predisposing condition that we come across. And that, anyone with IV drug abuse and a fever is going to get admitted to the hospital, because we have to be concerned about endocarditis. And so all the, diabetes, alcoholism are also risk factors for necrotizing soft tissue infection. Like none as great as IV drug abuse, and similar with spinal epidural abscess. So these are just,
Exactly.
and these are really hard, because these are patients who have, they have a tolerance to opioid pain medicine. It's, if they had a good way to calm themselves, they probably wouldn't have started using IV drugs in the first place. So I just want to say these cases are really hard, but the IV drug abuse is just such a red flag for something dangerous.
Absolutely. And that's why I wanted to bring this up, not so much because the hospital was concerned, but because we have so many abusers of substances and injection substances, depending on, what their dealer's choice is, that we may become kind of blasé about it. We're like, oh, it's another cellulitis, whatnot. And so I want to impress that we have a range of soft tissue infection that, yes, most of them we'll see is maybe cellulitic or abscess, but there is also this life-threatening condition called necrotizing fasciitis that we need to be aware of and know how to discern when we think that the risk is high for that, which Dr. Mock, you did a great job of explaining one of the sections on the next couple slides. But to have a high index suspicion, and just because they don't meet our sepsis criteria doesn't mean, by line, that we should be aware of this and try to be figuring out, does this person have that life-threatening thing? And if we don't want to call it sepsis alert, we can call it whatever we want, but to have the receiving hospital be aware of it, especially in our times now, where these are patients that might go, I mean, if he didn't look toxic, he may have gone to triage and sat out there, or that we put him in a room. He actually earns a room from the beginning, and that we end up waiting an hour to be able to see him. So trying to do the right thing for the patient, not only in identifying the risk, but also getting the right people involved early on.
Jackie, did he come in code 3?
No, he came in code 1.
Mm-hmm. How did
Yeah.
how did he end up getting, when did he get seen? How quickly?
Oh, I have to look at the timeline. I didn't look at, I mean, the rooms are essentially the same, Dr. Whitwer. So he was in room 20. So he wasn't in like east or west. He was at least in Maine. But it's because west is mostly closed. But it sounds like from the nurses that came and chatted with me about it, that he looked pretty awful, like diaphoretic, looked toxic.
Yeah,
And that they were like this.
And that's a clear difference from what the transporting agency documents.
Mhm.
I mean,
Yeah.
did he really change that rapidly in that few minutes? I mean, we've got what, 20 minutes of ambulance time, probably another 20 minutes of time on scene.
Yeah. So just more of a, for the crews to be aware, for the crews on this call to be aware, but also for the teaching points for everybody else. So there's soft tissue infections, and they're usually broke up. So there's upwards of 2 million cases per year in the United States that present to the emergency room, and they're usually distinguished by their location. So going from most superficial to deeper is erysipelas, which erysipelas is going to be involving usually just the epidermis, and then cellulitis usually involves like the subcutaneous tissue, more the superficial. And then necrotizing fasciitis is involving the deeper structures. So this could be the deeper subcutaneous, but usually the like lymphatic, the like deeper down all the way in the muscles, and potentially down to the bone in the myositis area. So yeah, so this is an example of erysipelas. It's a superficial epidermis infection. There's clear demarcation lines. This one's kind of not as impressive. Some of the images that I pulled up for erysipelas could be confused with cellulitis, but the big point is that the lines of demarcation are pretty abrupt. And then this image is a case of cellulitis, where you can see the redness is kind of like subtle transition to the non-cellulitic tissue. And then this is an example of an abscess, which usually involves the subcutaneous, but also could be the just below the epidermis, representing a pustule or an abscess or pus pocket, I guess you can call it. And then this one is an example. I'm trying to get the case reviews out of there. This is an example of what maybe necrotizing fasciitis would look like. It's very similar to cellulitis potentially, where it's going to be erythema, it's going to be warmth, it's going to be more extensive, not kind of diffuse in that area. There may be crepitus representing air formation underneath the skin, but it's not necessary to have crepitus or air in the imaging studies, and that you may see bulla or kind of blisters representing tissue death and like extravasation of the tissue of the cells, which these can be kind of purple or dark blue, and then you may also see skin necrosis. And then I put in here for exposure because you guys in the pre-hospital setting, can really help us in identifying what the most likely pathogen is, especially if the patient can't provide that, either because they're too altered from drugs or alcohol or from their infection, or that they're unresponsive and they just can't provide that information. So things that are important to give us an exposure, known exposure to would be like dog or cat bite. If they're diabetic, hopefully we'd figure that out. If there was like freshwater or saltwater exposure, which in our area, both can be present. So necrotizing fasciitis is the worst, the life-threatening, the most extreme when we talk about soft tissue infections. These include infections of these include not just deeper, but cellulitis, fasciitis, and myositis. The risk factors, as Dr. Mock had timely brought up, was that this includes IV drug use, diabetes, previous history of necrotizing fasciitis, or an immunocompromised state. And to remind everybody, immunocompromised state is pretty extensive. So that could be that they're getting active chemo, they're on dialysis, they have HIV or AIDS, they're diabetic, or that they're an organ transplant recipient. So immunocompromise is a kind of a wide net. The physical exam is that usually the patient will be toxic and their pain will be out of proportion to what you're looking at, and that's because of how extensive the injury or the disease is under the skin. They're oftentimes febrile, tachycardic, and then you can see a rapid decline in them. And then the exam, like palpating it, is that it might be hardened, or it looks like it should be like, your normal edema, we can push and kind of get like fingerprints or finger indentations, but this is really hard edema in that their pain extends not just where we physically see the skin changes, but beyond, which represents the infection below the skin. The gold standard for diagnosis is to take them to the operating room. Like imaging shouldn't be the main course to identifying it. If it's suspected, it's a urgent surgical consult and take them to the operating room to start debriding and trying to save as much tissue and remove the tissue in question. Management is going to be broad spectrum antibiotics and immediate debridement with surgery. And this image here is kind of a neck fasc progression. So this person came in with what we would say maybe skin necrosis, some erythema. There's a bulla. That bulla has gotten bigger. They took him to the operating room and debrided the anterior or the dorsum of the hand and the palmar aspect. So you can see it's pretty extensive, which here you may not have necessarily thought that it would require that much debridement up into the palm as well. All right, so then for Southwest region protocol, for sepsis, we want to maintain their SATs of 95%. And where I mentioned we should have at least been checking a temp and an end-tidal CO2, but remembering the vital signs to be looking for abnormalities in. And if there's two or more of the above of either febrile or hypothermic, tachycardic, tachypnic, or low end-tidal, and their MAP is, or they're hypotensive or they're altered, we want to be pulling the trigger for sepsis alert. Management is 2 liters of lactated ringers preferred, with close evaluation for the development of heart failure or pulmonary edema. So to decrease or stop the fluids if you're getting to that point where you're thinking that you're developing pulmonary edema in this patient. If they're hypotensive with MAPs less than 65, you want to start moving towards pressors, norepi, and then potentially epi. Any other questions?
Just one other comment. So I just want to make the link between this and another diagnoses that we worry about, like aortic pathology, mesenteric ischemia, acute limb ischemia, and then necrotizing fasciitis, all have in common that pain out of proportion to exam, which is also what you see in drug-seeking behavior. But I think our presumption, and so that I'm not saying like everyone needs 300 mics of fentanyl, but our presumption has to be that, okay, this could be, something dying inside, limb ischemia, necrotizing soft tissue infection. Like we have to at least entertain that thought before, and not exclude that until we can definitively exclude that.
Absolutely.
Yeah, exactly. I think for the medic, it's always safest to err in favor of the patient.
And even just getting access started,
Yeah.
I think that would have been what I really would, omitting the documentation of us blatantly ignoring their pain is probably a better choice than to document that. And then if you're fighting a patient that seems to be pain out of proportion, to start a line on them, if you can, or at least attempt.
There are other alternatives in narcotics too that we have at our disposal.
Yeah.
So at what point in his hospital stay did he begin broad spectrum antibiotics?
10:07. Wait, no, they was identified as sepsis alert early. I'd have to look at his timeline to tell you when he arrived there and how quick he was able to get the antibiotics. But it doesn't sound like there. Once eyes were laid on him, he was upgraded to a sepsis.
Yeah, good, because although in this case I'm sure it would not have made any difference.
No.
Even if he'd had IV antibiotics 2 days ago.
Yeah. Yeah. All right. Thank you guys for your comments. Would love to hear any from EMS for this case or any if you guys are wanting to chime in. So next case is of an 84-year-old female.
It's an amazing picture of an 84-year-old female.
I thought so, but to be honest, she actually looked similar to this, just grayer hair. So EMS gets called for an allergy, shortness of breath is what dispatches them out on. PPE, I forgot to put that in there, but I received this patient, so I can tell you that they had a mask, gloves, and I can't recall if they had eye protection on when they handed off the patient. Probably, because we usually try to get our PPE on. Anyways, vital signs, she's at a heart rate of 98, a blood pressure of 197/84, respiratory rate of 18, GCS of 15, SATs of 97%. They document a blood glucose of 148 and a weight of 170 kilos, which I don't remember her being that big, but anyways. Primary survey is that she was awake, she was anxious, her airway was open, she was protecting, but her speech was slurred. Her skin was pink, warm, and dry. In that her past medical history included AFib, hypertension, hypothyroid, and that she had recently underwent surgery for her spinal stenosis. She had told the EMS crews that 2 weeks prior, she had presented to the emergency room for an unknown allergen, in that, per her quote, they'd given me so much Epi and Benadryl that they almost intubated me, end quote. She was a retired NP. And then her history of this current illness was that she still doesn't know what the inciting event is, or the antigen or the allergen is, and that all of a sudden she started feeling like the soft palate of her mouth was starting to swell. So she took a Zyrtec, and her biggest complaints were airway swelling and difficulty with swallowing. She had no shortness of breath. So this is 5:53 in the evening. An IV was established shortly after patient contact. She was given 50 of Benadryl, and they note that her physical exam was, her breath sounds were clear. She had some obvious tongue swelling, no lip involvement, and they got vital signs at 12 minutes with a heart rate of 86, blood pressure improved to 153/67, respiratory rate is 16, GCS of 15. They initiate transport 18 minutes after contact, and that the patient stated that she didn't really feel like there was any improvement with the Zyrtec that she had taken or the Benadryl, and given her previous history of potentially almost needing intubation per her, they decided, after speaking with her and kind of using shared decision making, which they did document in their narrative, they started on an epi drip. They started her on an epi drip at 2 mics per minute, and assuming that it was mixed as a protocol, so 1 milligram of 1 to 1,000 and 500 mLs. They get another set of vital signs 2 minutes afterwards, and they note that her heart rate's 91, her blood pressure is 107/66, her respiratory rate's 18, her GCS is 15, and her SATs of 97%, and subjectively, she reports improvement in her symptoms. A little interesting about the change in her blood pressure in regards to the epi administration, and at 38 minutes, they arrived to the hospital. Mind you, they are coming non-emergent to the hospital as a code 1. So the good here is that they did a physical exam, they got IV access, they got early vital signs and trended them. They had the patient involved with decision making, which is always a good decision, but especially with somebody that has a healthcare background. And then they were concerned for anaphylaxis. Areas for improvement. If we're moving towards anaphylaxis, don't forget the other components to it. And ideally, if you're getting, especially on an epi drip, put them on the cardiac monitor. And then if you're treating a person for anaphylaxis and you're treating them with epi, if whatever route that you're giving, I think that this is an anaphylaxis case and you should be presenting to the hospital with appropriate reception. So code 3. In the emergency room, her vital signs were, and actually what I will say is that on Pulsera, they said they were coming code 1. My partner had said, they're bringing anaphylaxis code 1. So he had upgraded. I didn't know about this patient until I was assigned to them. He had upgraded them off of the Pulsera just for the treatment of anaphylaxis as a code 3. So even though they came in code 1, they got the reception of a code 3. And then vital signs, she had a temp of 36.8, heart rate of 89, blood pressure 149/72, respirators of 18, SATs of 94%. And she corroborated the story that EMS reported that she felt there was tightness in her throat, fullness to the superior palate of her mouth. Her speech was visibly slurred and she sounded kind of muffled. She had no rash, shortness of breath, GI, or neuro symptoms associated with it. And our management for her was, we treated her with epi. We stopped the epi drip and gave her an IM dose of epi. And then we gave her methylprednisolone and then finished up with famotidine to complete her treatment. She was observed in the department for 4 to 5 hours. All of her symptoms resolved, and with shared decision making, decision was made to go home. And reiterated that she did have an EpiPen, the importance of administering her EpiPen, especially since she has one for these kind of conditions. So, and the last thing I have here is that she thought maybe Tylenol was her allergen because after she had her back surgery, she was prescribed to do scheduled Tylenol, which she normally didn't take, and that seemed to be the only new thing from 2 weeks ago and the only continued thing by the presentation today. So I'm not, or that time. So I'm not really sure about that. So anybody have any questions, thoughts, concerns? All right. So anaphylaxis represents about 1% of all ED visits annually. And it's brought on by the immune system mounting a hyperreactive response to an antigen. It's IgE mediated, and IgE goes on to activate mast cells, which in turn leads to vasodilation, bronchoconstriction, vascular permeability, tachycardia, and gland secretion, which are all the things that we look for in determining if a patient has some of the signs and symptoms of anaphylaxis. Common causes are going to be stings, meds, foods, vaccines, immunotherapy for allergens, latex, and often idiopathic. Interestingly, of the foods, especially if you're trying to identify which food was potentially the culprit, 90% of the food-mediated anaphylaxis comes from just a handful of foods. So cow milk, eggs, soy, wheat, shellfish, fish, peanuts, and tree nuts. So if you are trying to determine what their exposure is, you can probably hit those food items and be accurate with identifying a food source. And then the diagnosis of this condition, I showed you, or I put a couple images of the National Institute of Infection and Allergen criteria, which is this box up here, and then the World Allergy Organization, their box for identifying anaphylaxis. But ultimately, it's at least 2 organ systems, remembering that skin and oral and mucosal swelling is considered 1 organ system. So 2 organ systems, unless they have hypotension, then you only need 1 organ system. So that's kind of like this summarized down. And then there's also a condition called, or another thing to watch out. I wouldn't necessarily call it a condition, but another thing to watch out for that can be present with anaphylaxis, which is biphasic reactions. And a biphasic reaction is another anaphylaxis reaction within 48 hours of the initial exposure, when the initial symptoms resolve, but they don't have another exposure and they have another anaphylaxis reaction. So that's what a biphasic is. And that's kind of when leads to why some providers, including myself, hold on to a patient anywhere from 4 to 6 hours, because 20% of the population that has anaphylaxis may have a biphasic reaction, although I'm aware that that can be anywhere from 6 to 10 hours after the initial presentation up to 48 hours later. So we're not going to hold them for that long, but that's my practice, and it might be a practice of some of the other docs here. So anaphylaxis, the symptoms, I think we're pretty well versed with skin and respiratory and potentially cardiovascular, but do remember there's also GI and neurological symptoms. So it can be hives, a rash, swelling. They can be just short of breath. There can be wheezing. They may have vomiting or feel nauseated or abdominal pain. They might complain of chest pain. They may be hypotensive, so kind of like your cardiac shock. And then neurological can be anywhere from altered mental status and a headache to a seizure. And then the management for anaphylaxis, the mainstay of the gold standard would be IM epi, preferably in the thigh as opposed to the deltoid, and airway management. I put it in gold as that is the first line. First line look for anaphylaxis, and that everything I could read was that healthcare and patients, even though they have access to epi, either through auto-injector or in their toolkit, oftentimes don't give epi for anaphylaxis. And I think that it's just a lot has to do with the fact that it's kind of like a stepward progression. If these don't work, they get worse, stuff like that. We finally go to epi. So reminder that if you're worried about anaphylaxis, you should be making sure the airway's secure and grabbing epi and then grabbing the rest of the stuff afterwards. IV fluids, if they're hypotensive, crystalloids are fine. Decon the area, especially if there's some type of like peanut or nut allergy that is related to contact with the skin. Antihistamines can be given, but antihistamines, steroids, bronchodilators, they are all less proven to be beneficial than as epi, but we still give it. And then vasopressors for refractory hypotension, and then they recommend consideration of glucagon if they're on a beta blocker and you're not getting a response to your epi and your other management. You can potentially consider glucagon to try to reverse the beta blocker component to it. And then the way that epi works is it reverses the bronchoconstriction, the airway edema, increases peripheral vascular resistance, increases cardiac output, and it stabilizes the mast cells that the IgE has activated to release its contents. And then epi, at least in general, I'm not speaking to our protocol, but our protocol may say the same, is that it can be repeated every 5 to 10 minutes after 2 or 3 doses. And if you're still finding that this patient isn't improving, or you think that there's a true concern for cardiovascular collapse, then starting them on an epi drip would be the next option, but making sure that they're on the cardiac monitor. So our protocol says for mild reactions, we'll be giving Benadryl either IV or IM, no more than 50. The left side is the adult version, the right side is pediatric version. For severe reactions, anybody that we think they're having airway component to it, or risk of airway component or shock, we'll be giving IM epi 0.3 milligrams of either their auto-injector or our stock, remembering that the thigh is the preferred administration site. And our protocol, I know, because I talked to the medic about this, our protocol does say that you can give an epi infusion at 2 mics per minute. Fluid challenge, Benadryl, albuterol, Salmeterol, and then potentially for pressors. So at 2 mics a minute, so I will disclosure, I did this math 5 minutes before we started this lecture. At 2 mics per minute, and this patient got it for 11 minutes according to our documentation, means that she received no more than 22 mics, which is equivalent to 0.022 milligrams, which means that she would still need to, she was 13.6 doses below 0.3 milligrams of IM epi. So yes, it can be given in a smaller quantity, but you're still undershooting the 0.3 milligrams of IM epi, and you would need to either increase the concentration or run it for another greater than an hour to be administering the same amount of your IM epi. So I would say, I may disagree or have a different of opinion, but I would say IM epi would be the recommended administration for patient and anaphylaxis, and you can have a low threshold to get your epi drip ready if you think your patient is also in cardiovascular collapse and will need subsequent doses.
Can I interject here?
Yes, yes.
Okay, well, if you look at our protocol, that is our protocol.
Yeah, but even at 4 mics, you're still, what you would give a patient.
Wait, stop. Our protocol says, A, give epinephrine and then begin epinephrine infusion. Give epinephrine IM at 0.3 for an adult or an epi, and then begin an epi infusion. The protocol is right there. And then the epi infusion says start at 2 mics per minute and go up by 2 mics every minute, depending on clinical response.
So there's the problem, because when I talked to the medics and I talked to some of the other providers, they said that they have the choice of giving IM epi or epi drip, that they're equivalent, and that's why this medic had chose the epi drip.
Well, I would agree. In this case, I might have gone with an epi drip, but I wouldn't have kept it at 2 mics per minute, depending on a response. That they weren't getting any response really, so they needed to increase it. So, but the protocol we did. I mean, you must be talking to an older medic, because we changed
Nope.
the protocol. We changed the protocol about a year ago.
New medic.
Well, we changed the protocol at least a year ago, if not more. Mark and so that for real anaphylaxis, we want them to start with an epi I am.
Then why, I think we should, so the way that this medic read it and the way I'm looking at it is BLS provider or IV delayed. So it should be, in my opinion, IM epi.
Wait, where are you?
Under severe reaction, it says BLS provider or IV delayed.
Well, it's because you can start an epi, if you have enough time to start an epi, but nevertheless, even if they begin an epi infusion, and I've treated anaphylaxis, especially older people who I worry about cardiac effects of too much epi. I've seen 0.3 milligrams give people trouble. I would never keep someone at a 0.2 or a point or 2 mics per minute anyway. But we just need, if we are deciding that they all need IM epi, then we should just change it to that.
I think that it should be IM epi and then with the option to give an epi drip or subsequent doses of IM epi. And if you want to consider the possibility of this is a patient that might be at risk of cardiovascular disease, then you can do the epi infusion, which is going to be a much smaller amount of epi than an IM epi. But if you've got a young person or a healthy person that you're really weighing the immediacy of anaphylaxis here and now over potential for an MI, that you're going to manage their anaphylaxis here and now.
Yeah, you have to be there. I'm a little surprised that the hospital just didn't turn up the epi drip at that point. They've already had by the time they'd evaluated her, this was going on for,
So
she'd had the drip for 20 minutes, and if it's I agree, it's underdosing if she's got 2 mics per minute.
She had it for 11 minutes and I was the doc. So I shut off the epi drip because for my practice, I don't do the epi drip unless they failed their initial administration. She was off. And the other thing is how well or how sick they look too. And she did not look critically sick. Yes, she had a muffled sounding voice, but at this point it seemed like she was pretty stable, that she was so they were on for 11 minutes with that epi drip, and they had spent almost 45 minutes between the two agencies on scene. So instead of, and the other thing is the epi drip being such a smaller dose, we stopped the epi drip and gave her 1 IM dose, where I think that if we're talking about keeping the epi drip, you would have to make sure that you're running it at the same amount to, for me, if I'm going to discharge a patient, I'm going to make sure that they're getting at least, and I'm thinking about anaphylaxis, that they're going to at least get the 0.3 milligrams of epi. That would be kind of the standard practice. So I would have had to kept her on that epi drip, which granted we watched her for 4 hours, but for at least another hour and a half at 2, or we could have just done the IM epi. So I ended up doing the IM epi, discontinuing the drip, and that's just my practice. I don't do an epi drip unless I find that the patient is refractory to IM epi or that the patient looks gravely sick and that I anticipate having to redose them multiple times.
Well, yeah, and
And then my first practice,
if you want her to get 0.3 mics of 0.3 milligrams, then she should have gotten, 5 mics per minute for an hour would do that. Pretty simple math.
Yeah.
Any rate.
does Dr. Mock have anything to say?
I mean, I think, I think you both have valid points, and I think the protocol is written in a way that allows for paramedic judgment, which has been the underlying philosophy here. I mean, what we're doing is we're balancing, how sick the patient is from anaphylaxis against the risk from getting epinephrine. So, an 18-year-old with anaphylaxis, like, the downside is nil. Whereas like, an 85-year-old with coronary artery disease, you've got, and I think you've gotten the room in this protocol to treat both of these patients appropriately. And I think that the point that we're getting at here is that if you elect for the drip, which is something you've got under protocol and is a reasonable choice, you really need to titrate it, and you need to, and so it takes a lot more active involvement than just giving that one shot, but it also gives you more room to titrate in someone where you're worried about the risks.
I think the underlying thing here to me is that, they sort of said, well, I guess they're thinking this is, is this anaphylaxis? Is this not anaphylaxis? Is this even a big, they didn't bring her in code 3. They didn't up her dose. They didn't do anything to, they were sort of ho hum. I'm going to bring this patient in, and I think if they're going to say anaphylaxis, they got to treat it as anaphylaxis. And that is something, I would be very cautious. I mean, this lady was quite a bit hypertensive to start with. And as I recall, you said she weighs 170 kilos.
She didn't weigh 170 kilos. She was not a 300 plus person. So I think that was a type somewhere.
So is this a 170-pound person? And so was 170 pounds instead of 170 kilos?
She was somewhere around 200. She wasn't.
Okay. Well,
she wasn't morbidly obese.
That's still healthy, and she's hypertensive. And she's 84. I'm a little cautious with big doses of epinephrine on old people who are hypertensive and probably have, if
I
she
think
doesn't
that we
have
should say that
disease.
in our protocol, because it doesn't say that we should be doing an epi drip for over an IM dose for elderly people. It just like the way that at least this medic, and I don't know if there's any other medics on this call, says that they have the option to give IM or infusion just because they have IV access or not. So,
but they don't have an option to give 2 micrograms for the entire treatment of the patient, because they're supposed to do it to match the symptoms. It's like if you were going to treat hypotension with epi, you also start at a smaller dose, but you titrate it to effect, just like norepinephrine. Everything you treat for anything IV. So we could probably work on this protocol to make it ironclad and straightforward, but like Dr. Mock just said, that we have given some room, and maybe we need to withdraw some room for paramedic interpretation and discretion and decision making.
I'm not saying that anyone's limited. I'm saying that we're having people interpret it as they're potentially giving less than the standard for epi if you're talking about for anaphylaxis, especially over a period of time. And then, devil's advocate, this patient had told the medic that she felt better at 2 mics per kilogram or 2 mics per minute. So do you go off of her subjective response, or do you go off of the fact that she still has a muffled sounding voice?
Well, if your bottom line is that you want to get, you could keep it at that, but then at that point, if we want to get if you want to get a full 0.3 milligrams in, then we just turn it up in the hospital and watch her for that hour.
Yeah. No, I think that's why I wanted to bring it up, is because it seemed like there was confusion about how to treat anaphylaxis. All right. Thank you guys for you guys' input. EMS, do you have any input? All right. The next case is a 64-year-old male who was drinking at his home bar, and he had suffered a fall. So he had fallen off of a bar stool in his house. PPE usage was appropriate. He was awake, but he was slow to respond per documentation. His area was open. He was protecting it. His skin was pink, warm, and dry, and he had no active bleeding. The first set of vital signs was greater than 10 minutes. So my process is I don't report it if it didn't happen in the first 10 minutes. He was 85 kilos. No past medical history was reported, and he had just lost his balance off the bar stool. This was not witnessed. He did not lose consciousness. His family heard the commotion. They moved him off the floor into a chair, and he was complaining of numbness in his arms and his legs, and that he said he could not move his extremities, but he could sense them. A blood glucose was obtained prior to arrival, which was normal. This call took place around 2:55 in the morning. Spinal precautions were documented at 12 minutes, but I suspect that they were done earlier than that because the transporting agency documented that the fire department was sitting with the patient with a collar on. So I'm assuming that they took C-spine precautions early, so it wasn't a 12-minute delay. The physical exam showed that there was an abrasion to the bridge of his nose and that he had a non-tender spine. He had sensation, but he was unable to move his upper extremities either by grip or move, and that he was unable to move his lower extremities. At 15 minutes, they got a first set of vital signs. His heart rate's 67, his blood pressure is 92/61, his respiratory rate's 16, and his GCS is 15. They initiate transport at 17 minutes as a full trauma code 3. Mind you, the hospital downgraded down to, I think it was a trauma consult based off of height. So at 18 minutes, his SAT's 97%. They place an IV. They don't document that they give many fluids. At 32 minutes, another set of vital signs. Heart rate 74, blood pressure 86/44, respirs of 16, SATs of 93% on room air, GCS of 15, and they arrived to the hospital at 37 minutes.
Quick question, did this come in as Pulsera, and did they
Yes.
note in Pulsera that he was paralyzed?
I would assume so because it came in through Pulsera, and all of the documentation for EMS is that this patient was quadriplegic. And when I saw this patient, no trauma surgeon was with it at all. So they had to have I didn't realize that they downgraded this until I was reading through their EMS's documentation that they had put this as a code 3 trauma, full trauma. So
Okay.
I'll get back to the hospital about that side.
Okay, good.
So the good is that their index of suspicion was high. They documented and transported as a code 3 full trauma. They did a complete neurological assessment. They checked a blood glucose. They got IV access. They did serial vital signs. Ideally, I would love to see vital signs done within the first few minutes, 5 minutes, but no longer than 10 minutes. Make sure when you're documenting like your spinal precautions that you're documenting, especially if you're worried about like acute neural compromise, that you're documenting it accurately. If you took C-spine precautions, document it that you took it earlier than many minutes into the call. If your patient's hypotensive, I think if I remember correctly, that the EMS crew said that the patient stated that he's always hypotensive, but maybe a little bit of fluids, especially now that you've got a patient that you're worried is having an acute neurological compromise with a mechanism of injury. May want to consider 12 lead in somebody. Maybe this patient's hypotensive because they've got a STEMI. So, try to eliminate surprises at the hospital and try to do the most appropriate with the patients. And then scene time, they weren't horribly long, 17 minutes, but trying to, if we're doing full trauma, recognize that we're looking for less than 10 minutes unless you document that there was issues, either extrication or access or whatnot. So be mindful about your scene times. In the emergency room, the patient had no midline cervical, thoracic, lumbar, spine pain. He had no priapism. He was weak in all of his extremities, but he was more weak in his left upper and his right lower. He stated that he could sense touch in all 4 extremities. His workup revealed an alcohol level of 201. His lactate was 4. His CT imaging, he ended up getting pan scanned, and we assumed that he fell forward off of this bar stool because he had facial abrasions. So CT imaging was negative for anything acute, but his neuro exam persisted and was concerning, so we MRI'd him, which showed that he had central cord contusion or central cords syndrome involving a cervical spine with severe cervical stenosis. By the time a few hour or so after he arrived, he developed priapism and he had urinary retention. Neurosurgery and trauma surgery was consulted based off of this patient's findings and presentation. He went to the ICU. On hospital day 3, he had a laminectomy involving C3 through C6 and a posterior arthrodesis. During his hospital course, he was persistently hypotensive, requiring imidodrine and Florinef administration. They checked his heart to make sure that it wasn't contributing to his hypotension, but ultimately they called it neurogenic shock. He had persistent neurogenic bladder, so he had a Foley placed at hospital day 5, and his final diagnosis was central cord syndrome, cervical stenosis, resolving quadriplegia, and neurogenic shock and neurogenic bladder. He was discharged to rehab. So I thought that was a great case. EMS did a great job, and a reminder that, yeah, bar stool doesn't seem like that high, especially with such a profound neuro exam. So a little discussion about central cord syndrome. So it's one of the incomplete spinal cord syndromes. There's probably like 6 or 7, so this is one of them. And this image here on the left here shows the insult to the spinal canal or spinal cord, more of like the central location, representing more of like the anterior horn. These patients will have incomplete quadriparesis. Their upper extremities are more affected than their lower extremities, and their sensation will remain intact. The mechanism of injury for this is going to be a hyperextension injury. So that this is like a person who was walking on the sidewalk and fell face first and hit their chin on the sidewalk. So it hyperextends this ligament. Ligamentum flavum is like a kind of stiff, either from trying to think of the word I'll say that it's not supple, and this ligamentum flavum will be kind of hardened. And when they have this hyperextension injury, that ligamentum flavum will impede on the spinal cord, causing this condition. In regards to trauma, non-traumatic causes would be like intermedullary tumor or a syringomelia. Management for these patients is really, really important from the initial onset, is to identify this condition and to immobilize them. So pre-hospital really has a high role to try to improve their course, over their disease course. It's controversial that they would give steroids or maintain MAP goals of greater than 85 to 90%, depending on practice patterns. But there still is in recommendation, although the data supporting that is not exactly clear. And then some patients will have conservative management, no surgical intervention, and they'll leave surgical intervention for when their symptoms don't resolve, or that the symptoms plateau, and then they'll do surgical intervention to decompress the area to improve their neuro outcome. So I thought I'd add our trauma protocols. Technically, this patient's age, lack of anticoagulation, and height of fall doesn't meet, but the neuro exam definitely meets. And I think that you would, as far as I could tell, it would fall under paramedic judgment. But either way, I thought that this crew did an excellent job of not getting distracted by the common things that we upgrade patients. And I will get back to the charge nurse that decided to make it a trauma consult. And that is it. No, that's not it. I have one more case for you guys. Anybody have any questions? Okay.
How old was he again?
64.
Oh, okay. That's, well, this still gets him older than 60, which puts him into high risk anyway. And the fact that he had a blood alcohol of 0.2 kind of means he kind of falls kind of loosely.
Yeah. Yeah, they said that congenital cervical canal stenosis, but severe.
Yeah. Well, then when he gets any hyperextension would probably do him no good. Well,
Yeah,
let's hope he does okay with
yeah,
his rehab.
they actually said that he had actually had symptoms preceding the fall. He just ignored them.
Yeah, I'm curious. I noticed on that it used to be on our trauma thing that paralysis would get you an automatic trauma entry. So I'm not sure whether we're missing something or not, or something dropped out of the order sheet.
Yeah, I looked. Oh, wait, there it is. Yeah, it's right under paramedic judgment. Sorry, paralysis. Yes.
Yeah.
So both of them.
Yeah. At least give them at least would give them a activation for at least a modified trauma, if not a full trauma.
Yeah.
Yeah. But there's something to bring up to the hospital because they have to teach the nurse if you're paralyzed. That's
Yes. Absolutely. And I didn't realize that that was the case until I read EMS's report. So the next case, last case, it's a quick one. Thank you guys for your attention. Is a 45-year-old male, transgender male, who had was actually doing the volcano run at St. Helens in August. I think the temperature of that day was 80 degrees from what I could find in the weather searches. So they had called for shortness of breath. PPE usage was appropriate. Patient was awake, but confused per the responding agency. I think the event EMS had said that they were confused because you'll see all the GCSs are written as 15, but I think that had resolved. So airways open, protecting, skin is pink, hot, dry. No vital signs because the event agency, I don't have any vital signs for them. Past medical history is none reported, no known drug allergies, and according to the story was that he stopped running at 3 p.m. and he had completed 30 miles of the 32-mile event. So EMS got a call around 4 p.m. They made contact with him at 4:30 and found him to be slightly confused, had a headache, nausea, body cramps, and he had already been receiving IV fluids and carbohydrates, but still felt a little short of breath. They documented that his BFAST exam was negative, and by the time the first agency got a hold of him, it was 7 p.m. And this was a rendezvous. So there's three black numbers up here because one ambulance got a hold of him and rendezvoused with the other ambulance that transported him. So that's how that looks. So at 3 minutes, his heart rate was 59. His blood pressure is 108/57, respirators of 12, GCS of 15. He was given a total of 2 liters IV fluids with the first ambulance. His blood glucose was 176. At 15 minutes, they initiated transport to a rendezvous with the other ambulance, and they gave him 8 milligrams of Zofran for his nausea. They did a 12 lead, and they documented that they thought that he had global ST elevation and peak T waves concerning for hyperkalemia. I looked at it. I thought it looked more like early repolarization, but I think that's definitely, given the nature of illness, it's definitely a consideration to be worried about hyperkalemia, dehydration, and acute kidney injury. But because of the ST segments being more convex, I think this looks more early repol myself. They rechecked his vital signs a couple more times. He was a little bit bradycardic, his pressures maintained, and at 55 minutes, they rendezvoused with the other ambulance, who the other ambulance repeated his 12 lead, which looks similar to the first 12 lead. And they initiated transport towards the hospital at 62 minutes, did a couple more blood vital sign checks, which remained pretty much stable, and arrived to the hospital at 107 minutes. So I thought that this was really well-run case. They managed heat emergency and dehydration. They managed getting serial vital signs, serial 12 leads, recognized something concerning, but didn't necessarily go down the route with, all right, this is a STEMI activation and we're going to be treating for a STEMI. I think they kept it, they recognized it being abnormal. It stayed stable. They recognized that there was probably other things contributing to what was going on, and that they opted for a healthy person to rehydrate them as opposed to starting to shift them, which I think was a appropriate decision in this case. And they recommended that the patient be transported for further evaluation due to their concerns, which I think is also very appropriate. You know, as I was writing this case up, I was thinking, well, if they were thinking that the patient may be experiencing pericarditis with ST elevation in their interpretation in all leads and hyperkalemia, maybe they should chat with online medical control. It doesn't seem like that really there was anything pushing the subject here, but that might be a outsider's view of looking into, well, if you thought these two conditions, why didn't you treat it? And then by the time that this patient's contact was made, it was probably their temperature was normal, but maybe checking a temperature to ensure that it wasn't still elevated and requiring intervention in regards to that. In the emergency room, he was afebrile. His heart rate was 54. His pressure was 97/59. His respiratory rate was 14, and his SATs of 98%. He was a patient of a partner of mine, so I did not see him primarily. He had told the doc that he had drank 8 Camelbacks. I don't know what the equivalent volume is for that, for his 30-mile run. They did a CT of his head because of his confusion, a chest x-ray because of his complaints of shortness of breath, and labs. His creatinine, assuming that he was healthy, was elevated, so he had acute kidney injury with a creatinine of 2.16. His CK was 963, so that's creatinine kinase or muscle breakdown product. They checked it again, it was 1,144. His troponin, his high sensitivity troponin was 158. He had hematuria and evidence of CAS in his urine, and his white blood cell count was 15,000, but they thought that this was probably more stress demargination. Because of his elevated troponin and some of his EKG, and because of his EKG concerns, cardiology was consulted, and they had stated that this is a known complication of long distance running, and that as long as the second troponin isn't rising, that there'd be no reason to admit him for an in-STEMI. His second troponin was actually downtrending. I think it was like 144. So he was discharged home after repeat creatinine and CK and troponin, and he tolerated PO challenge. So I thought this was kind of an interesting case, as my partner was like, I can't believe we're not admitting this patient, and that everyone thinks that this is okay. His EKG looks very similar to what EMS found, which made me just do a little quick search for long distance running sequela. And
Jackie, was his sodium okay?
Yeah, it was normal. I think it's like probably 136. Yeah, his sodium was okay. And anyways, so that's a good question for sure, especially with the heat exhaustion and exertion. So completing an ultra marathon, which what I was reading was anywhere from 50K to 100K, is associated with damage to muscles, which you would imagine. Eccentric contractions, which is like running downhill, like mountain running, is most severe to the damage to their muscles, in that the muscles damaged are not just your striated muscles, but also your cardiac muscles, in that we'll expect elevations in the striated muscles, CK, as well as the troponin, in that unlike for a STEMI or an NSTEMI, they'll have lower elevated troponins that bounce back within 48 hours as opposed to 5 to 7 days. So just a little bit I thought I'd share to you guys, as I was unaware of that myself. And then heat syndrome, I thought that they did everything in our protocol that was warranted. Maybe just add a temperature check to that. And that is it.
Yeah, just a quick comment. A helpful part of the history is to figure out if the patient was taking in sodium, because particularly if not, be at risk for hyponatremia. And especially if you fled this guy with normal saline, you can correct that too quickly. So just at least get that in the history and think about hyponatremia if the patient was drinking free water but not taking in sodium.
That's actually, thank you for bringing that up. That's a good point. Great point. All right, well, that is all for August case reviews. Thank you guys for your attention. Hopefully we brought up some topics that will make you think or add to your already, your knowledge base already.
Good cases. Thank you.
Yeah, thank you.
Thanks.